Welcome to AETCM, the Emergency Medicine channel. Today we are going to discuss about a peripheral arterial occlusion case. A 61-year-old male patient was brought into ER with complaints of right lower limb calf pain since last 2 months, which worsened over the last 2 days. On initial 10-second assessment, patient was conscious, oriented and obeying commands. Primary survey, his airway was patent. There was no pooling of secretion, gurgling or hoarseness of voice. Breathing, his respiratory rate was 18 per minute. His chest exertions were normal. Air entry was bilaterally equal. And saturation was 100% in room air. And there was no use of axillary muscles of respiration. Circulation, his heart rate was 80 per minute and BP was 120 over 80, and all peripheral pulses were felt equally and bilaterally except in the bilateral popliteal dorsalis pedis and posterior tibial arteries.
Both the sides.
Both the sides. Disability, his GCS was...
if only one side peripheral pulse is absent, lower limb. What all differential diagnosis you can think?
It can be either because of an emboli, which is...
The first thing you'll think. You don't think about normal variants. Lower limb arteries, many patients can have altered anatomy.
Yes.
So in that patient, you don't get any pulse. There you require Doppler study in emergency room itself. Some patients you can see, patient will be absolutely normal, but you don't feel the lower limb pulses, distal pulses. That is because of anatomical variant. It may not be going through the periphery, it may be going through the deep plane. Okay. So that should be, whenever we see anatomical variant should be dot, because a lot of patients can come like that. Here it may not be that it is a different thing. Okay.
Then it can be because of some trauma-related cause can be there, or it can be usually in PVOD and all, both the limbs will be involved together usually, and but if it is because of an embolic spread, it can be into a unilateral vessel.
Okay.
Then his pain score was 8 by...
Emboli means from where?
If it is from the, because of AF and all, if it is from the heart, if emboli is going, and then it can be unilaterally.
Okay. Normally emboli from heart in peripheral circulation, it will be very, very small shower of emboli. It may obstruct peripheral circulation rather obstructing a big artery. Big arteries are always from a local pathology, a local dislodgement of a thrombus, not routinely from heart. Unlike you have CVA, that is from heart, but peripheral arteries it is not very common. It is almost like it's a peripheral obstruction that is dislodging and producing complete obstruction.
His GRBS was 180 milligram per deciliter. Pupils were 2.5 millimeter bilaterally equal reacting. Pain score was 8 on 10. Exposure, his temperature was 98 degree Fahrenheit and hypothermia was prevented by blanket. Adjuncts, he had a pain, so we have given him a 1 gram paracetamol IV was given, and since his distal pulses were not...
What are the conditions you get claudication pain or peripheral arterial occlusion during cold weather or cold temperature?
Raynaud's phenomenon.
How do Raynaud's phenomenon present?
There will be a pain, bluish discoloration will be there. Such things.
Vasospasm occurs. So anytime the patient is environmental factors or pain factors, stress factors, for whatever reasons, if at all acute onset of vasospasm, widespread vasospasm occurs, patient will complain of lot of pain and bluish discoloration of the peripheries will be seen, but it is reversible. So once the triggering factors are taken off, the patient...
It's a tricolor response. Initially pale, then blue. If you warm it, it will become red. Okay. So, but you can sometimes get the pulse also in that type of patients.
Then since he did not have peripheral pulsations, we just planned for an arterial Doppler, but we have a handheld Doppler in the ED. So with that we checked.
When the peripheral pulse is not felt, what level in the artery? See whether you started from lower down going up. So what are the pulses for dorsal pedis, posterior tibial, popliteal?
While palpation, his bilateral popliteal dorsalis pedis.
Specify. Okay. To that level itself, it is diminished or absent.
On palpation, bilateral popliteal, dorsalis pedis and posterior tibial were not felt. So with handheld Doppler, when we checked, we could get the pulsation of bilateral popliteal, left posterior tibial and bilateral dorsalis pedis we were able to get, but the right posterior tibial we were not able to get.
Still certain amount of blood flow is still established.
Yes, sir.
No, not completely. Okay.
Then we took an ECG. ECG was showing a normal sinus rhythm only. Usually ECG will be taken in cases of acute arterial occlusion to rule out any atrial fibrillation is there or not.
It is not for atrial fibrillation alone. Atrial fibrillation, you can get the pulse and you can see the monitor. Why we are taking a ECG in this type of patients? Somebody is saying arterial occlusion. You told it can be emboli from the heart. Okay.
There can be simultaneous occlusion to the coronaries also.
Okay. LV clot, but ECG will not pick up LV clot.
Coronaries, if it is there, so MI will be there, sir. So
Okay.
we have to rule out that also.
Okay. Some patients will have chronic hypertension.
Yes.
And like aortic dissection or something. There also you get same type of problem. You can get absent pulses. So that also should be ruled out. That is a need of an ECG in this type of patient. But as you told, atrial fibrillation is one of the cause for all type of arterial occlusion that also can be picked up.
Ample history. There was no allergies. He was a smoker since last 40 years and stopped like 2 months back after he developed this lower limb pain. He was diabetic for last 15 years and is on OHS. He is taking ecospirin and cloplan atorvastatin. Cause is not known, but I think it is because of the PVOD, which was diagnosed 2 months back. Patient had history of pain over both lower limbs, which worsens on walking, and it subsides within 1 to 2 minutes after taking rest. He noticed that since last 2 months, and he was taking treatment for that. Then he developed a prick injury to the base of the fourth toe, which he didn't notice. Following which it developed into an abscess, and IND was done 3 weeks prior to presentation to a READ. Then he was taking cefixime antibiotics for that, and it got subsided. But now he presented with right lower limb calf pain since last 2
What
weeks.
is the coverage of cefixime? There is a cefixime is a third generation cephalosporin. What is the coverage?
Gram positive and gram negative coverages.
Okay, it is predominantly gram negative, but it has got good gram positive coverage also. Okay, you are told about claudication pain. What are the different types of claudication pains?
Usually classical claudication pain because of a PVOD will be like patient will be walking, and then after some time patient will start feeling pain, and when the patient take rest within 2 to 5 minutes the pain will subside. But if it is because of a neurological claudication pain, in such pains the pain will start immediately when the patient starts walking, and it will subside after some time.
Okay, so pain will be on standing, and on walking it may relieve. On forward bending it can be relieved. It is due to?
Compression of the...
Okay, sometimes it is compression or spinal canal stenosis. Because of compression, spinal canal stenosis will occur. That is a reason for the claudication pain. Okay.
Lower limb local examination, do you have any findings?
I will come to that.
Okay.
So on examination, we directly went on to the lower limb examination. On inspection, the bilateral lower limbs were dark, hyperpigmented and shiny. The muscles looked atrophied, muscle bulk was somewhat reduced, sir, but there was no gangrene visualized. There was no joint deformity, swellings, any redness or any bite mark seen. He had a 2 into 2.4 centimeter healed ulcer.
What is the foot arrangement, whether it is a flat foot or something? Is it important?
Yes, sir. He is chronic diabetic, so there can be charcot foot like deformities were there, but that was not seen in him. He had a 2 into 2.4 centimeter healed ulcer on the plantar aspect of the right fourth toe, extending dorsally, maybe because of the healed ulcer. There was no
on the dorsum of foot. On the dorsum of
on
foot.
the plantar aspect extending to the dorsum.
Okay, so what do you think that is? What are the possibilities to develop ulcer there?
In this patient he had a trauma which he didn't notice, and it developed into an abscess which turned
Okay.
into.
Otherwise, normally in diabetic patient, how do they develop a ulcer in the plantar aspect?
The sensations will reduce because of diabetic nephropathy, sir.
Neuropathy.
Neuropathy, okay.
Yeah, neuropathy. So basically, since the sensations are decreased, even trivial traumas, they won't be able to feel it.
It's
And
not because of trauma.
non-healing-
Many patients you are seeing here, it is due to
microangiopathy,
callus formation. Callus formation, and later it leads to the ulcer formation in the foot. That is the commonest thing. And some patients who are not using proper footwear, then they can develop like trauma you discussed. But the most important thing is callus formation. Okay, that's why podiatrists always clear that callus area in the foot. Okay.
There was no collection, discharges or bleeding, and on palpation bilateral lower limbs were cold to palpate. Sensations were reduced bilaterally as compared to the proximal aspects. And the pulsation we have already mentioned. While we are palpating below the popliteal, from the bilateral popliteal region, we are not able to palpate the pulsation.
Cold limb you told. What is the reason for that?
Because of the reduced perfusion to those areas, it can be called, or it will be secondary to some hypotension or anything. But
This is due to autonomic dysfunction. One of the finding in autonomic dysfunction in peripheral neuropathy is cold limb. And here it can be aggravated due to arterial occlusion. Okay.
In arterial occlusions, in the local examination, we will have to look for the 6 P's. There can be pain, paresthesia, it will be cold to touch. Then there can be paralysis can be there, pallor can be there, and pulselessness. Last is the pulselessness.
All examined. All these things examined.
All these things examined or not?
Clinical examination.
Clinically, we will.
And also don't forget about the lymph nodes.
Yes, sir.
Draining inguinal and popliteal lymph nodes. Okay.
Then we check the angle brachial index for this patient. So in the right side it was 0.83 and on the left side it was 0.91. So that we will be checking by dividing the systolic BP of the angle and the upper limb, sir. So if it is coming more than, if it is less than 0.91, that means patient is having a peripheral vascular occlusive disease, and if it is coming less than 0.4, that means it is a severe peripheral occlusive disease.
Which one will be divided by?
The angle systolic BP will be divided by the brachial systolic BP.
Good.
On reassessment, other system examination were within normal limits, sir, except for the sensation of the lower limbs. It was within normal limits. Treatment, when we
So what investigation you do in emergency room? You are told ECG is taken.
ECG is taken, then handheld Doppler we can do, then arterial Doppler can be done, sir.
Okay.
We can do a USG guided arterial Doppler can be done, sir.
Acute limb ischemia is a clinical diagnosis.
It's a clinical diagnosis.
The minute we diagnose, we have to urgently
Okay.
refer the patient for vascular surgery for further.
Correct.
So first we have to subdivide this patient according to the Rutherford criteria, and based on that we have to decide when to call the vascular surgeon. If we are looking at the patient, if it is the patient is having, if the sensation and the motor power of the limb is normal, and if we are able to get arterial and venous pulsation in the Doppler, then that we can wait on that patient. But if that patient is that is a viable patient. If this patient is threatened, it can be either A or B. So in the A category, there will be sensations will be mildly impaired and the motor function will not be affected, and the venous pulsation and the arterial pulsation, when we are checking, it will be reduced, somewhat reduced. But in the type B, the sensory will be moderately impaired, and some motor impairment will also be there. And in an inevitable injury, the motor sensation, the motor power and the sensation will be lost, and there will not be any pulse felt. So that patients might be having some gangrenous features also, so they require amputation. So the patients
when you are telling about gangrene, it is better to describe what type of gangrene it is, because we are calling a consultant. So they would like to know whether it's an arterial disease or venous disease just by describing the ulcer part. Okay. or gangrene part?
Gangrene usually in chronic occlusive disease will be a dry gangrene, sir, because of the reduced perfusion. So that area, the muscles will be atrophied, that area will be very dark and all. So we can manage only the threatened cases. So threatened cases, we will have to immediately involve a vascular surgeon and plan on revascularization. And revascularization also, when we are planning on that, we will have to find the etiology, what is actually causing this arterial occlusion. Either it can be because of a thrombi or can be embolic. Thrombi can be because of chronic atherosclerotic occlusions, or it can be secondary to some aneurysms or any ulcers which have occurred, or it can be because of some hypercoagulable states also, thrombotic
Hypercoagulable state in artery. Which condition? In this age?
In this age, unlikely, sir, but in hyperhomocystinemia associated with smoking and all.
This age, hyperhomocystinemia is the only one condition in male which can produce arterial thrombus. Other than the diabetes or whatever, smoking and all. Okay, that is very important.
Main
if
to
it is female, a female patient, APLS syndrome.
Protein S deficiency.
APLS syndrome is one of the most common condition which produces arterial thrombus, not protein C, protein S. They all produce venous thrombosis. So, like you told, it is APLS syndrome, and SLE can produce arterial thrombus. Otherwise, arterial thrombus is not very common. But diabetes, smoking, all can produce diffuse arterial atherosclerosis.
Main causes diabetic and smoking. Then other contributing factors can be dyslipidemia, then hypertension and all. So if it is because of an embolic shower, it can be either from the heart or from an infective pathology or a mycotic aneurysm also can cause.
Hypertension, how do it produce arterial occlusion?
Endothelial damage.
It produces vascular injury. From there, platelet aggregation, cholesterol aggregation forms a clot. Not clot, it's a plaque.
Or it can be because of iatrogenic causes, sir, because of secondary to any cardiac procedures, or it can be because of some areas, if you are giving an arterial puncture or an arterial line is placed, that area there can be some arthritis can be there, or that areas, if accidentally some drug is given through that area, that can form crystals and occlude that arteries. So that also can be there, sir. Then if we are getting such patient, in the ER we can check the angle brachial index, and if possible, if we are having different size of BP cuffs, we can check the segmental blood pressure, and if the BP is varying more than 30 millimeters of mercury, then it is significant. Then we can proceed with an arterial Doppler.
So pain management will be one of the most important thing in ER. Other things, it is not in our hands. So you'll have to do pain management in this case.
Usually the analgesics, since it is an arterial occlusion, usually pain can rest. If this patient is having rest pain and all, usually analgesics might not work for this patient. We can try paracetamols and opioid, but for ultimate we have to treat the cause, then only we will get the ultimate pain relief. So we did the angiogram for this. This patient's creatinine was normal, so the vascular team directly planned for a CT peripheral angiogram for this patient, which was showing mild PVOD in mild arterial disease in the aortoiliac segment, and he was having superficial femoral artery severe stenosis with right side popliteal artery plague with distal posterior tibial artery diffusely diseased and narrowed.
So in this one of the important thing is whether it is a localized pathology or diffuse pathology. Diffuse pathology means it is very difficult to treat. You will have to give only symptomatic. But localized pathology, it has to be treated as soon as possible.
If it is because of a thrombotic cause and all, then we can plan on giving an intra-arterial thrombolytic agents like recombinant tissue plasminogen activator or urokinase can be given. The streptokinase can cause bleeding, and alteplase, which is given for stroke, cannot be used. These things can be used, sir. Otherwise, but if it is because of an embolic shower, because of an AF, or if it is because of a chronically diseased condition, such cases we cannot give any drug management. We can start him on heparin 80 units per kg bolus dose, and heparin infusion can be started. But this patients might require an angioplasty, peripheral angioplasty like treatment, or a bypass grafting should be done, sir. So in this patients, they did the superficial femoral artery was cannulated, and they stented the artery which was involved, and they have given NTG, local NTGs was given to relieve the spasm of that area, and but that diseased part was not that healing, and the procedure was not very successful, so they planned on bypass grafting on a later basis was planned for this patient.
How do NTG relieve the pain?
It can cause vasodilatation can happen, so that will relieve the spasm.
Okay. It is more of a venous dilator, but it can also dilate the arteries, peripheral arteries. So it may not work in complete occlusion.
Artery occlusion.
That is the only issue. Anything else?
The ergot positioning may produce arterial spasm also.
Ergotamine. Where we use ergotamine?
Migraine.
That can produce spasm.
Previously they used to give after delivery.
Delivery.
Uterine. Nowadays they are not giving.
Actually, these type of drugs are contraindicated in patients who is having coronary artery disease or severe hypertension. It can further produce vascular spasm. So ergotamines are not good drug in migraine in a patient who is having cardiac disease. Okay. Thank you.